This is the first session in our webinar series, with our focus today being on the medical perspective. The reason for the webinar series was that we were finding at Bultbird and Kemp that more and more of our clients who have spinal cord injuries are having discussions around stomas, either as inpatients or further down their rehabilitation journey. I'm sure that many of you who are joining us on the session today have had similar discussions as to whether to stoma or not to stoma. We are very grateful today to be joined by Professor Emmanuel, who is a professor in neuro-gastroenterology at the University College London and a consultant gastroenterologist at UCLH and the National Hospital for Neurology and Neurosurgery at Queen Square. Over his professional career, he has dealt with a vast majority or a vast number of spinal cord injury patients, and we are extremely grateful for him in joining us today and sharing his experiences with us. I'm sure the session will be invaluable to those that are joining us. Professor Emmanuel, over to you.
Thanks ever so much. I appreciate the chance to spend time talking about something which I think is really important, and I'm glad that you're running the series to allow people who are having to face difficult choices to have another source of information. As it was implied just now from what Rhiannon was saying, what I'm going to say is very much in terms of the generic rather than the specific. But I hope it sort of seeds things that allows you to then take things further into the discussion about your cases. And equally, there's stuff which I recognize how, as well as a sort of professional, sometimes it's easy when you get information to think, yeah, but my particular situation is this. How do I translate what you said into this? And that often is what other people are thinking. So, as doctors and nurses, we see our perspective on things, and I try and reflect the patient's perspective that has been garnered over 30 years of working with spinal patients. But inevitably, I won't have that first-hand knowledge. So everything I say which follows is going to be sort of based on the kind of science and the experience I've had. But if there's parts which feel that it doesn't quite hit what you're asking, then please do feel free to engage, because the questioning part is what I really want to spend time with. So I will therefore make the assumption in starting this that to start at sort of the most basic level, and that is kind of patronizing for those of you who know lots about this, or even have stomas yourself. I reckon some colleagues on this phone call webinar may be people who have a stoma already and are looking for advice about fine-tuning. So some of this is really basic, apologies, but it'll be harsh on those who are starting their journey not to have an understanding. So a stoma is derived from this kind of Greek word for mouth, and essentially it is a stoma is essentially like a mouth, a stoma, but at your in your tummy wall. If you think about your gut as one long tube, which it is, from your mouth down to your bottom, and again, apologies if I use inappropriate language. I try not to swear, but I'll occasionally slip into clinical language sometimes, and so I say anus instead of bottom, and that offends people. Again, I apologise. But from your mouth down to your anus is about 8 meters, about 25 foot for most of us, depending how big you are, but roughly about that long. And there's a lot of it coiled away in there, and different regions of that continuous tube go at different speeds. But the only parts that you voluntarily control are swallowing at the top and deciding to poo or pass through to the bottom. Everything else in between happens because of the nervous system propelling things along, and a particular part of the nervous system called the autonomic nervous system, which moves things along. Now, when you've had a spinal injury, depending where your level of injury is, you'll get various levels of severity of compromise in those involuntary nerves. Some of them will be preserved, even in people with a complete injury, which is why people will still have some function, but some of it will be lost. And in particular, that kind of fine-tuning between, when you're healthy and you're able to think, oh, I need to open my bowels, I better leave this meeting and go and do that. You have that nice, healthy, helpful warning, find an opportunity, or equally, if it's not a good moment, to squeeze and hold on. But when you don't have that intact spinal innervation, you don't have that. And so the big problem is that you have in this long continuous tube, which is moving along at mostly its own rate, that rate is slowed down. So a stoma essentially says, because we can't rely on the rate of movement being consistent and the control of the exit being consistent, because obviously you can control the input because that's well above the injury level, but the exit part is up. So in some people, where we can't get treatment right, where we can't get the balance of medications or electrical stimulation or suppositories or irrigation, any of the other things that we try and do, then we need to think about an operation. And it's worth saying that when I first started doing this work in 1995, the published data for the number of patients going through a stoma at that point was between 10 and 14%, depending which centre. So about 1 in 10 to 1 in 7 patients had a stoma. And that was probably a reasonably accurate reflection. But if you think about, there's also some bias between what gets published and what happens in real life. But the latest data we have is that that figure has fallen to about 3%, between 3 to 5%. So from 10 to 12% to about 3 to 5%. Now, I'm not saying that's a good thing necessarily, because there are some patients possibly who are languishing, who simply having stomas, who aren't. So the rate of stoma isn't the thing I wanted to dwell on, but to say that, just put it into context, saying it's something which a minority of patients have to think about. And one of the reasons that that figure has fallen is, I think, that patients are being offered other treatments. So the number of patients who are dissatisfied with therapy and therefore went to a stoma was high in the old days, and it's slightly less now. But there are also patients in whom a stoma isn't possible. So I'll come to that in a moment. So what is a stoma? A stoma basically is like just swapping where your bottom is, that hole there, that mouth down there. It's a mouth here and a mouth bottom, and then deciding to put that onto your tummy wall. So the reasons that's done is for one of the two basic symptoms that happens in people with spinal injury and their bowel dysfunction. And one is severe constipation, and one is bowel incontinence. So when we can't manage constipation symptoms, like all the various juggling we try and do of medications orally or rectally or stimulation or anything else, or we can't control incontinence, then we have to think about this as an option. Broadly speaking, which part of the bowel is brought out depends on which of those symptoms is the primary one. So some of you will have read about things called a colostomy, where the colon is brought out, versus an ileostomy, where the ileum or small bowel is brought out. What does all that mean? As I said, from your mouth down to your bottom is about 25 foot. There's about 2 foot of your gullet. There's then about a foot of stomach. There's then about 18 foot of small bowel, 16 to 18 foot of small intestine. That's where all the digestion and nutrition absorption occurs. So at the end of the small bowel journey, what was food has now become a kind of a pulp, where all the nutrients and important things have come away from it, minerals and vitamins have taken away from it. And you're left with this kind of pulp, a residue, with lots and lots of liquid and secretions your body's pushing out. And that's about 1.5 litres of that a day, which leaves from your small bowel to enter that last 6 foot of the journey in your colon. And by the time from your mouth to enter your colon, that takes about 3 to 4 hours all in. A few seconds in your gullet, about an hour in your stomach, a couple of hours in your intestine, while all that absorbing and secreting is going on of all the nutrients and goodies. But the last sort of 20 hours in a healthy person that's spent of that transit of material from your mouth down to your bum is spent in the colon, that last 6 foot. So about 1.5 litres of this liquidy pulp enters your colon, and then that gets more and more dehydrated from being that liquidy pulp into becoming like soft mayonnaise, and then like soft putty, and then like more formed putty, and then like a soft sausage, and then this consistency changes as you move through that colon slowly. Your colon is basically wringing that pulp dry, just taking water. There's no nutrients to absorb because that's all been done further upstream. It's all this. So basically, I'm telling you all that because it means that for patients in whom the problem is primarily of incontinence, where we can't control continence of the bowel despite everything we've tried, then in that situation, we tend to say, well, colostomy may be a good option. Why a colostomy? Because then all you're doing is you're bypassing, instead of coming out of your bottom end and catching you out at bad moments, not allowing you to work or train or be intimate or have social occasions, because your bowel may let you down, or only managing those things by avoiding food or taking loads of drugs or making life miserable. then in that situation, sometimes a colostomy is an option. Whereas an ileostomy, we'll think about when people have severe constipation. Sometimes we do a colostomy for them, but the problem with a colostomy in patients with constipation is that it often means you still have to take lots of laxative, because just bypassing where it comes out of by maybe a foot, instead of bringing out of your bottom end, it comes out of your tummy further down, that doesn't really change how slowly things move in that last. Because as I said, in a healthy person, that colon journey takes about 20 hours. In patients with spinal cord injury, it can take as long as a week. So instead of being a day, it can be 7, 8 times that long. So in that situation, they can still say, look, I've got a colostomy, thank you very much, but it's still not emptying, and I'm still uncomfortable, and I'm still bloated, and I'm still everything else that I think causes, is caused by my constipation. So in that situation, if people want to avoid laxatives, then we'll consider an ileostomy. And then there's one other, so there's either a colostomy or an ileostomy. And then the other terms you may have heard are what they call a loop colostomy or an end colostomy, or loop ileostomy or end ileostomy. So loop or end. And an end is the simple one to understand. It's like a spout. If you go to an old cathedral or a church and you see a spout where the rainwater comes out, or down on the gargoyles, that's what it is. The bowel is brought out, whether it's the colon or the ileum, the colon or the small bowel, in other words. That's just brought out like a spout, and it doesn't quite go with the force of rainwater, thankfully, but it comes out, and then whatever comes out of your bowel then gets into the bag that contains it, and that's done. Whether it's colonic content, i.e. like a poo from a colostomy, or ileostomy content, which is like this thick porridge, which doesn't smell like poo because there isn't much bacterial breakdown of it. So that's the other big difference between the output, not just the liquidity, but also the odor. A colostomy output smells like a poo, because it is, because all the bacteria have broken that mush down, versus ileostomy just smells more like mud, nothing unpleasant particularly to it. So versus a loop, so that's an end colostomy, ileostomy. A loop is where the bowel, which is like a string of sausages, go all the way down this long tube from your mouth down to your bottom end. A loop of that bowel, whichever bit of bowel it is brought out through the tummy wall. So there's a knuckle of it there. And then the surgeon, she or he, makes a cut so that in that loop, so that knuckle gets out of cut, so that then there's a loop of bowel there. So it's not an end spout, stuff coming out of it. It's a knuckle of bowel with a little hole made there so that the stuff comes into the bag. Now, what's the difference between those two? By having a loop, it means that some content, some of the secretions, some of the little electrolytes can trickle downstream, because the vast majority, 99.9% of it, comes into the bag and you dispose of that. But tiny amounts will go down there, and that can help keep the bowel further downstream healthy. Because guess what? Your bowel downstream likes having poo in it. That's what it's evolved to have. So for some people, when they don't have content going down to it with a loop, then that makes that bit of bowel a little bit sore or inflamed. And so there's a balance to strike. But of course, the flip side of that is that for some people, if it's not done carefully, or if they're unlucky, then too much can go down there, and then they can get randomly little plugs which drop out of their bottom, and that can be very distressing. So the decision about colostomy or ileostomy, the decision about a loop or an end, is very much something that we need to think about. So there's always 4 options: loop or end, colostomy, ileostomy. Some of that is dictated by your symptoms, some of that is dictated by what your situation looks like best. Now, there's situations, and I'm not talking about anything about the run up to colostomy, or ileostomy. So I'm not talking about any other treatments, the things that we sometimes fiddle with diet, or the laxative discussions, or the suppositories, or the enemas, or the irrigation, or the stimulation. There's a whole lot of other things. That's not part of today's discussion. As I'm invited back. Today we're going to focus on the question of the stoma. What's very clear, if you look at the data, and I was going to present some slides, but I thought actually, what slides end up being a way of doctors and nurses hiding behind sort of stuff which sounds technical and fancy and doesn't then puts distance between you and I, which is already great by the virtue of being in a webinar. But what is clear is that if you look at things that matter to patients, quality of life, ability to function, ability to train, ability to travel, ability to have intimate relationships, you look at those things, the overwhelming majority of patients who have a stoma say they would do it again. So according to which study you want to quote, the one that I quote most often is the one that is the largest one that's out there, not our one, unfortunately, but our data was very similar, which is that basically about 85% of patients say they would do it again in a heartbeat, and their biggest regret is that they didn't do it earlier. That's an important thing I'll come to in a moment. They say, what do you regret about the decision? I didn't do it earlier, is the commonest reply. In terms of the quality of life scores, the measurements we make, in terms of people's ability to work, in terms of ability to travel, all those things are the biggest reasons that are given. So for the vast majority of patients, 85% of patients feel that their quality of life has improved hugely, that they would do it again. Would you recommend it to a friend? Similarly, 85, 90% of people saying, yes, they would recommend it to a friend who have the same set of symptoms. Of course, things can go wrong, can't they? The things that can go wrong are that, unfortunately, sometimes it doesn't do the thing you hoped it would do. That's the commonest thing to go wrong, unfortunately. So everyone worries about surgery of stoma, thinking, oh God, I have a misadventure in the surgery. But remember that stomas are done really commonly, unfortunately, in healthcare. Patients get cancer, patients get bad polyps, patients get diverticular disease, patients get colitis. And in those situations, sometimes a minority of the patients need stomas. So stomas are really commonly done things. So the technical parts of surgery are not usually a challenge, unless you've had a really scarred abdomen. And of course, some spinal cord injury patients sustain their injury through major trauma. And if you've had a really traumatized abdomen, lots of surgeries or crush injuries or whatever, then that can make it technically quite difficult to basically find a space. So sometimes a surgeon will be able to say to you, look, I'm afraid I just can't safely do an operation. But the commonest thing that goes wrong is not that. The commonest thing that goes wrong is the fact that it just doesn't work. People still get some soiling sometimes, despite the fact that they do for incontinence. It's a minority, a small minority, about 5%, or they still say they're constipated. And that's why we sort of make this very careful distinction between majority constipation versus majority incontinence and go with the ileostomy and colostomy discussion as we had earlier on. Because that's really important. By doing that and think about it more carefully rather than just saying, oh, I prefer not to have a smelly thing, so I'll do an ileostomy. That can be the wrong choice for some people. Or I prefer to go infrequently, so I want a colostomy. That can be the wrong choice. It's more about the symptoms that you should think about first. So that the symptom non-response is the biggest thing. And of course, the big tragedy from our point of view with that is that we can't really undo it. You know, with a tablet I start on with you, or an enema or a suppository or stimulation or whatever else, if it doesn't work, we stop it and there's no harm done. Whereas with an operation, it's done. And so for something not to work after we've done something which we can't undo is it's a bigger step for the patient and for the team to decide on that. So I think that's the thing that you have to remember. Surgery is not something you can undo in that simple way. Of course, there are some patients that you will know who do have their surgery undone. But remember, you've then had 2 operations. You've then taken a damaged organ and made it more damaged by fiddling with it twice surgically, and function tends to be poor there. So we don't go into these operations saying, oh, we can undo it. It's a bit like a patient said to me, and I've used this ever since, like a vasectomy doc. You don't go to a vasectomy thinking, oh, I'll undo it if I have a new relationship, which I fancy better, and I want to have children. You go into it saying, yeah, my family is done or not happening or whatever I'm having. So go into it thinking this is the correct decision for you as you're at this point. The other things that happen that you will hear about are because patients with spinal injury more often tend to be seated, you can get complications from that because the kind of constant pressure. You know, when you're upright, you're able to relieve the pressure on your abdomen by passing through your hips into your legs. But when you're seated, more of that can put through your abdominal wall. So there's more of this bloating tendency, and that can cause the stomas sometimes to either prolapse, i.e., push out, or retract, i.e., pull in. And then that may need further surgical sorting out. So we know that about a third of patients with spinal cord injuries or MS who have a stoma will need a further procedure on their stoma at some point, like fixing a little, what they call a hernia, i.e. a little area of weakness near the stoma where a bit of the bowel bulges beside it, and then the surgeon may need to close that off, and she or he will do that. So about a third of patients need further surgeries around their stoma, but those are not usually very major, and compared to the things people are often living with, it's often that's not the major issue. The thing I was saying earlier on about, and I'll stop talking and do some listening in a second and pass on to other colleagues who speak, is that there are beyond why don't we do stomas? some people. Obviously, that's the reason I said about having a very scarred abdomen where the surgeons can't physically bring out a stoma. But the other reasons sometimes are that patients have got sort of can't cope with the idea of this. And sometimes we think this is the right thing to do because everything else is not going to work for you or is troublesome. But we just worry that sometimes patients get really fixed on the idea of getting everything absolutely clean and they want to irrigate it. And sometimes what we see is that patients end up trading a bottom that they can't see, which empties in a rather random way, for a stoma which they can see, which they overstimulate. And sometimes overstimulating that can cause separate harms of mucus leakage and discharge and prolapse and bags not sticking as well and skin breakdown. So sometimes you may find doctors and nurses being a bit resistant to this, and it may feel a bit harsh. It's worth having the discussion. I'm talking here in absolute terms, and also is in the individual intimacy of a relationship you have with your caring team. But it's worth trying to understand why it is the team say it isn't the right thing. It's very rarely about it people saying, "Oh, we can't be bothered, just live with it." It's very rarely about you have a really complicated upbringing. Sometimes it is. Sometimes it just isn't the right thing for the person because we know from experiences we've had when down to the wrong people, it goes badly wrong. So the last couple of things I was going to say about this were, if we look at the satisfaction rates I've quoted you now of 85 to 90%, which is what the data shows, back in the day, it was nearer about 60%. And a lot of that was those patients who thought it was going to be something and it wasn't. So if you go into your stoma thinking it's going to make pain go away, it never does, unfortunately. I'm sorry to be so miserable. If you go into it thinking it's going to make bloating go away, it doesn't, unfortunately. If it's going to it thinking it's going to make my spasms go away, it's really unlikely to. So the stoma does what it says on the tin, as they say. It basically brings out poo via a mouth on your tummy instead of your bottom. And that can help you with continence or constipation. It can't change the other things that have happened as part of your injury. And it comes with a cost not being reversible, and it comes with the cost of the fact that in a small amount of patients it may not work. And then we have to then say, right, we then have to go back to using our laxatives or to using an irrigation system via there without getting too obsessive about it. So, you can still irrigate stomas sometimes for constipation. We do that in a few patients. So it's not that your stoma didn't work, okay, you're done, you're thrown to the dogs, nothing we can do about it. We still will look after you and try the best, but it's different. We're working on operated on bowel rather than the bowel that you had by nature and disease. So that's probably a lot of stuff there. So that sounds really basic, but please ask me challenging questions, but I'll shut up and listen.
I just had one question for you, which is, I know that you say that, it's important to consider the symptoms and kind of get, I suppose, knowledge or intel as to how your bowels operate and the difficulties that you have. Are you having bloating, constipation, what the issues are? So what part of the journey, someone's newly injured, do they, do you need months worth of information, weeks worth of information? I mean, as a team, the spinal cord injury team, we've just done a freedom of information request to all of the spinal cord injury units throughout the UK as to what their policies are on offering stomas, because as we understand it, there's a difference between the various units. So I was just wondering from the medical perspective, what your thoughts were on that.
Yeah. Well, I was cheaply getting a request as I would love to share that data and maybe write up a paper about that because that would be really interesting and be highly publishable. But putting that aside, so remember that we always talk, and it's probably not entirely accurate, but you will hear people talking about spinal shock phase of an injury, and just like immediately after an injury, there's a period when essentially your body's getting used to its new electrics and the disruption. And so making a decision in that early phase certainly isn't a good one, especially a decision about surgery. But we've gone from saying, well, nothing is done at all for the first 6 months, which is what happened in the 1990s when I started, which is that in spinal shock phase, don't make any decisions, we just manage the bowels this way until we've gone from there to thinking, okay, well, sometimes we introduce irrigation early on for some patients. Sometimes we don't use digital stimulus. So, but we still wouldn't say a stoma is the right time. So I think what I would say is don't make any decisions before 3 months after your injury. Most
Yeah.
people who are on this webinar will be long since that. And then thereafter, it's not about how long you've had symptoms for. It's then about what it's, from my point of view anyway, it's what disruption is it causing to you.
Mm-hmm.
I always say to patients, and any of my patients who are on this webinar, I apologize if you've heard this before, but there's three things we aim for in care for you. One is that you avoid accidents. You can't live a life if you're worrying about fecal incontinence. So we try to avoid fecal incontinence. Number two is we avoid spending too long in the toilet. Some
Yes.
patients will spend 2, 3, 4 hours each time they do it once or twice a day. And that's just, tough. And you only have, 16 waking hours to spend a quarter of that in the bathroom is unlikely. And then the third thing is not interfering with the quality of life too much. Inevitably, it's going to be a change. Before the injury, pooing was something you didn't think about. It took 4 minutes. But now it goes to be something you have to think about, plan, get help with, and it takes half an hour. So anything which doesn't disrupt the quality of life, which doesn't cause you to spend too long, which doesn't cause you accidents, that's what we're aiming for. We don't care how often you go, what it looks like. So I would say it's not about how long you've had symptoms for or how long you have to measure symptoms for. It's what disruption it has had to your life. If you said to me, for example, that on the bus in this morning to work, if I had a bowel accident, if I had fecal incontinent on that bus, I will never take that bus again. I
Yeah.
will never take that disruption of body. Now that could be because me being sensitive, and then I'd see a doctor and they'd say, listen, try and get serious about this, try and manage it. But so it isn't, it's about you don't have to suffer. So I guess what I'm trying to say, you don't have to suffer for years and months to say, I've now earned my ticket to see a surgeon. It isn't like that. The surgeon is part of our team who sees a small number of our patients. It's about the interruption to quality of life.
And do you see a difference in approach between, I suppose, different ages of SCI patients or different sexes, men v women, different approaches taken by different cohorts?
You're asking really, really big questions, really important questions. So you could definitely collaborate together on writing a paper. So I mean, the reason this is really, really important is this, in 30 years that we've been doing this, I've been doing it. We've gone from the typical injured patient being a young man in their mid-20s, early 30s, to the typical spinal patient that is new nowadays, being an older person, and genders roughly more equal because of the safety things that have happened in sports and motoring,
Yeah.
and because of the fact that surgeons are doing more interventional things for the older population, and people are living longer and injuring themselves when they fall and so on. So we've seen that trend. And in that time, so what some of the changes in demographics I mentioned about stoma care from about 12% to about 3%, some of that could reflect that an older patient group, where we're doing less for them, maybe right or wrong. We don't really see from our data anyway. We've performed stoma surgery on about something like 40 patients, 42 patients with spinal, with non-cord equine, supraspinal cord injury, acquired Tarko, of however many, and between Queen Square and Stanmore. And we don't see a difference in gender or age. We're seeing older patients now, but that's probably because of the injury rather than anything else. The only other thing to say is that if you have any pre-existing disease, we had a few patients with spinal cord injury who previously had Crohn's disease or colitis or previously other diseases, then bowel disease, that has informed our decision sometimes to do a stoma earlier or not to do a stoma. I should say things like IBS. If your doctors have given you a label of IBS before, that isn't a disease in that sense. That could change our decision about stoma.
And is there any psychological workup that's required from a medical perspective or psychological considerations? Or is it purely?
So yeah, no, so you can talk in two ways. You can either do a very formal, I'm going to refer you to psychologists before that, like we do for plastic surgery for bariatric reasons or breast augmentation or reduction or whatever. There is that we don't do that, and most centers don't require that. We certainly try and explore as clinicians, non-psychiatrists, non-psychologists, how the patient feels about their body, and if we had a patient who's really, and some patients are really phobic about the idea of something pooey, which they can see, which the other people could see or smell. That doesn't happen, of course, because the bag technology is so good now compared to how it was. Um, and the So if we sense as a patient who's got a real worry about it, who's the right thing, then those are the occasional patients where we've said, look, what are your fears? And then we'll introduce them sometimes to other patients. Some of them on this
Mhm.
call may well have been advocates for their sisters and brothers who've had injury and spoken to patients. We'll introduce them to stoma teams to say, here's what the reality looks like. We'll have a measuring up session where we sit with them and say, here's where you can be. Let's put a dummy bag on your tummy and see how you cope with that thought for 2 days. Go and live with it, come back and see what questions you've had. So there are things we're trying to do to help people adjust it if they have a problem, but we never try and coerce somebody. Because ultimately, there are some patients who just say, look, it's never for me. I can't bear it. I had a bad memory of my granny having it when I was a kid, and
Yeah.
it's never for me. And it's okay, let's work our way around that and accept that you
Um,
can have to compromise.
we
Sorry.
have a question from an attendee who said, does an SCI affect your digestion at any level and stop you taking some nutrients in? They've recently found that food is passing through quicker and some items are undigested in their bag.
Yeah, thank you. So what is true is that so the actual function of the gut in terms of how it works as an absorptive organ, that doesn't change between pre or post injury. And this has been, obviously, we don't know that information from humans because we never put people through that. But in animal studies that were done before, people have done studies looking at before an injury and after an injury in animals, and there's no change in their function of their gut. It has the same number of cells to absorb and secrete and all that stuff. But what is true, it's the correspondent maybe relating to, is the fact that sometimes when you have this injury, that the combination of accelerated brake pedal that the nervous system is, because that's what it is, it's everything is a bit of a push and a bit of a pull, that balance may swing. 95 times out of 100, it swings to slowing things down. But there are some times in which it pushes things through faster. So we know if we look at minerals and back to humans now, forgetting animals, if you look at pre and post injury, their mineral and vitamin levels don't change in terms of nutrients that they absorb. They often get lower vitamin D better because they're more often indoors. And if you normalize that, then it goes up. So there's no real mineral vitamin changes in how your gut absorbs, but the rate at which it moves through may be different. Therefore, some things like tomato skins, bits of kale, those kind of things which take longer to digest. They still get digested, but they take longer to break down the external appearance. They may whistle through a bit.
Okay. I have a question for you, Professor Emmanuel. When I was talking to someone about us doing this webinar series, and they themselves started the process of thinking, and she said, oh, I think it's something that I would be more interested in doing when I'm older, because at the moment she's younger, she's coping with her bowels, she can manage her bowels herself. So my question to you is there could you get to an age where basically you would find that people would say to you, you're too old to have the operation? So if you think that you want it in the future, do you kind of need to be thinking about these things a bit earlier than maybe when you actually feel you're going to need it?
Yeah, great. Thank you for that. So I think the answer to that is there's the random stuff that puts people off having surgery, as in doctors and nurses recommending it. And that is that if you develop heart disease or lung disease, which are more likely to occur as you age. So they may suddenly, you may, I don't be absolutely fine, suddenly, God forbid, have a heart attack, develop bad airway disease, and then they say, look, actually, your lungs wouldn't stand an operation of any sort. So therefore, we're not going to do, unless there's an emergency, an operation on you. So it's that random stuff that happens, such as the progression of time and disease for non-gut reasons. There's no real gut reason, however, which says that an older person's stoma performs less badly. So that data I was saying about our rates falling, we have tried to look at that and say, are we doing less because these are older people? And are we subconsciously making some judgments saying, oh, it's not worth it. They haven't got that long to go, therefore it's not worth it. And we would say, we thought about, we went at a really open mind, looked at the data really carefully to see how's our decision making? Are we taking longer to make decisions for older people and therefore, and we didn't see that. So I can only speak for ourselves, but we had a look at ourselves. But there's no real reason why age, most stomas, if you look at it the other way around, most stomas are done for cancer, diverticular disease, and those are things that happen much more to older people. So, my oldest patient just had a stoma for diverticular disease, for diverticular disease was 92 when she had it, and she's now 104, 105. So age isn't a recommendation or a contraindication unless something else happens.
And you talked briefly about kind of the change in statistics and the change in data that you're seeing. I suppose $1 million question, where do you see the stats going in the future? Do you think more people are going to have stomas or less people? Kind of, what do you think the trajectory is going to look like?
Yeah, so I've now got the benefit of bald head and grey hair, so as me to make speculations because I've got less time to be caught out about talking nonsense. I think I would say my anticipation is that stoma rates will increase slightly from where we are now, and that isn't a bad thing. When you look at device companies who are manufacturing stimulators or irrigation, they say, "Oh, we want to drive stoma rates down." I think, well, I want patients to have the best quality of care. I don't and the best outcomes. I'm not obsessed by, and I'll put it another way, which is that our time to stoma surgery. So although we're doing way fewer, our time between first seeing us and having a stoma has fallen in 30 years. I've been doing this. So the time to stoma surgery when I first started doing this as a junior doctor was of the order of about 6 years between seeing a specialist and having a surgery. It's now about two and a bit years. So by the time we give people a chance to work through everything else, and that's despite NHS waiting lists having gone up a lot in 30 years. So I think the decision making, and my point being that I think what we're trying to do is not to think about sort of anyone who's ever seen that ridiculous treatment pyramid that we devised, my big regret 20 years ago, which made it seem as though you climb up a pyramid until you get to the top. And the top of the pyramid was stoma. And we don't win it. It's not that stoma is the amazing thing that you want to reach at the top, like Indiana Jones. It's not that holy grail. It's just that it's an option. And so I regret the pyramid because it made it seem like there's a set of pathways which ultimately ends in a stoma anyway. And it isn't. There are some patients, that's not quite true. A patient I saw in January this year who is a Paralympian and wants to train and doesn't want to travel for her activity and doesn't want to be taking any medications which may compromise her ability to get a positive or to compromise her abilities to form. I'm trying to avoid saying what she does. And compromise her ability to may compromise her with a drug test if she gets positive because she doesn't know what's in the drug. She decided to have a stoma, so she had an injury 15 months ago, and she had a stoma in March. So about 2 years after her injury and about 9 months after seeing us. So, I think the point is that we're trying to sort of say, look, when it's the right decision for the person, we don't see it, well, you have to spend 3 months doing laxatives, you have to spend 3 months with suppositories, and 3 months with digital stim. That kind of idea is torture. So it's more about trying to tailor.
And practically for people who are on this webinar or subsequently listening to this webinar, if they want to engage in that process and want to kind of get more information, because one thing that we often hear is once people have sadly left the unit, started their kind of rehabilitation journey in the community, access to this information and access to these resources is quite limited. And that's one of the reasons for kind of putting on these webinar series. So how would you or what advice would you give to those looking to kind of explore stomas and alternative treatments? How would you suggest they engage in that process?
So I think I'm hoping that there's very few patients who've had an injury who aren't part of some rehabilitation scheme. I know it's my hope, and I know the reality is that is the hope of a man who sits in an ivory tower, 2 ivory towers, where I get people to come. And there's a lot of patients who never enter a spinal injury unit, let alone and are managed in general service. So the first port of call, whilst we still have them, thank goodness, in the NHS, is your general practitioner. Make an appointment to see your GP, and it is something which is all the MASCIP and all the UK and European and American organizations say you need to be under primary rehabilitation service. It's something which we're working on NICE to get them to say that when somebody has a spinal injury, they need to be under a neuro rehabilitation service. So I've yet to meet the GP who said, when a patient said that to them, because I meet a lot of patients at events in the flesh and get contacted after webinars, and patients who said, look, I've been languishing 10 years, 15 years without. And I said, same thing, go and see your GP. I'm yet to meet the person who said, I went to GP and they said, go to hell. GPs will say, oh, well, we don't have one here, but I would refer you to Salisbury, which is 60 miles away if you want to be bothered, or refer you to Sheffield, which is 200 miles away if you want to. And at that point, because I think that way is, I would say, the best way. It's not the only way. I'll say that. I'll give you a very long answer, sorry. That's the best way, because then you're in a service where patients like you have been looked after. It isn't just yeah, okay, I'll do a stay with you, fine, yeah, I'll just add you to my list of other patients I'm doing, fine. Because the alternative way is to say to the GP, I want to go to a general surgeon to discuss stoma options. And they will do that. In some ways, that's easier because every person has a local hospital where this is not so commonly done. The danger there is, unless you get somebody who knows this or has done, there's danger that you just get lumped into the general service. And the nature of this is that spinal injury patients are a bit different. Your ability to prepare your bowel before an injury is compromised by because you're maybe in a chair or less mobile. Having an accident before the event, before you have a colonoscopy, having the bowel preparation can be really difficult. Sometimes getting dysreflexia. So being able to manage all those things is a really important part. So yeah, if you're lucky and you have a general surgeon who's really got a good service, and there's plenty of them, then you may strike lucky. But the very best thing is to be under, and even if they only see you virtually, I mean, COVID has changed it. So we do so much of the neuro rehab stuff now virtually, and just ask you the questions about spasm, swing, bowel, bladder, sex, all this. And then just as actually, I would flag my bowel, it's really a mess at the moment. So yeah, ideal thing, first support with a GP, ideally in the service, if not a local
and
surgeon.
not be afraid to ask those questions or to push for a second opinion or referral for that information.
I know it may sound depressing for people listening to this, but most people when I do stuff internationally on spinal injury and neurogenic bowel, they still regard Britain, and I always defend us, as being a place where there's very good care given to spinal injury patients, compared to the only place that people are envious of us compared to us is the Nordic countries. But French colleagues, Spanish colleagues, Italian colleagues, American colleagues all talk with, I wouldn't say reverence, but respect for the service we have in the UK. So we do still have this. I know it's hard to access, but yeah, getting to us via your GP. We're not looking for work, but we know there's people out there who need help. So we are looking for work for that reason. So we've got plenty of work, but we want to help people.
Great. Well, that concludes today's session. Thank you once again, Professor Emmanuel, for joining us and sharing your knowledge and insight into the medical considerations around stoma. We're really grateful for you to take the time out of your busy diary to join us. Our next session, we will be joined by 2 spinal cord community members who will discuss their personal experiences and the considerations that they have taken or are taking around stoma. One of them has a stoma and one of them is in the process of considering undergoing the process to get a stoma. So please do join us for our next webinar series. Just double checking. Oh, we've just had some positive feedback from some of the attendees thanking you, Professor Emmanuel, for a really useful webinar for someone that's on the waiting list for a stoma. So thank you. As I said, people have found it really informative. So please join us next time, and thank you once again. Bye-bye.